Our next speaker is Dr. Reinhard Kloiber. He has done his fellowship in diagnostic radiology and nuclear medicine at McGill University, Department of Radiology at Foothills Medical Center and University of Calgary since 1982. He has various roles in the clinical services, administration, training programs, and research. Started the PET program at Foothills Medical Center since 2005. He has a career-long interest in infection imaging, has been using FDG PET CT for infection since 2007. Welcome, Dr. Kloiber, and he's going to talk about FDG PET and infection.
Well, thank you very much, Dr. Yunus. I'll be speaking about FDG PET CT for infection. Can everybody hear me?
Yes, yes.
Oh, okay, very good. Okay, I've always considered it my responsibility to look at all options in order to provide the best clinical service possible. And for infection, I used gallium for about 25 years. In the late 1990s, started switching to white blood cell imaging with mixed results. And the only real new option that has come along in recent years is FDG PET CT. It has a very high sensitivity for detection of infection, and here's how it works. The activated white blood cells take up a lot of glucose and consequently FDG. So basically, FDG PET is a variant of white blood cell imaging, but there's a very important difference, and that is that the FDG is a small diffusible radio tracer, and once it's injected, it distributes rapidly throughout the body and labels activated white blood cells in situ. It's totally independent of white cell migration, and white cell migration is limited in high pressure areas such as the spine and the intramedullary cavity in the case of osteomyelitis period. Quoted sensitivities range from 90 to 100%. But at the same time, FDG is a non-specific radio tracer. It's positive with just about any pathogen, be it bacterial or fungus or even viruses, as long as it generates an immune response. It's also positive with with sterile inflammation, and the prototype condition is sarcoidosis, but also included are a variety of inflammatory conditions, ranging to the from sarcoid, which can be intensely active, to lymphadenitis from recent vaccination. More relevant to infection imaging is inflammation associated with healing tissue damage, such as from trauma, surgery, or advanced degenerative disease. Like gallium, FDG is taken up by a variety of neoplasms, and it also has its unique biodistribution and artifacts. So in order to maximize the specificity and get it anywhere close to the sensitivity of the procedure, it's necessary to have well-defined and standardized interpretation criteria. Even then, it's not always possible to make a definitive diagnosis, but the results can serve as a guide to where to biopsy or what other interventions to proceed with. So how does it compare? How does it compare with other options, including white cells and gallium? Well, PET has by far the best image quality. It's inherently tomographic, and even at depth has a resolution of around 4 millimeters. With a gamma camera, resolution drops with distance from the collimator. It's around 10 millimeters at depth with technetium, and even higher with medium energy collimators for indium-111 and gallium. Patient acceptance, it's PET-CT is very patient-friendly. It involves a single visit, an injection, a 1 hour uptake period, and 10 to 30 minutes worth of imaging, depending on whether you're doing a whole body scan or a specific site. White blood cell imaging and bone gallium requires multiple visits, often over several days. Radiation dose is comparable for PET-CT and technetium for technetium white blood cells. For indium white blood cells, that's however at the expense of a very low dose because of the high splenic radiation dose period. Bone, forget I say period, I'm just thinking of dictating. In terms of bone gallium imaging, the radiation dose is significantly higher, especially if the dose is increased to improve the quality of the SPECT imaging. Cost of the procedures, we looked at it in detail in 2013 when I first gave a presentation on this topic, and PET-CT was the lowest, although you know, it's not substantially different from the other modalities. Costs have certainly increased in the interval, but it should be a proportional increase. The take home from this is that the cost is similar between the various modalities, so the choice of which one you use should be based on best results and not on economic factors. So why is PET-CT not used more? And I'm sure it will be in the future. Who uses gallium, for example, for staging and treatment response in lymphoma, or to look at cardiac sarcoid? But use of FDG PET really depends on where you are in the world. In Europe, it's widely used. Various associations interested in infection have recommended PET-CT, FDG PET-CT as the procedure of choice in fever of unknown origin, in spine infection where MR cannot be performed or is inconclusive for initial diagnosis, and certainly for treatment response where improvement on MR is significantly delayed. For large vessel vasculitis and infection in grafts, and for cardiac sarcoid and implantable cardiac devices. It's also commonly used as an alternate or ancillary procedure for many other infectious conditions. In North America, it's a totally different story. Medicare and Medicaid did not cover FDG PET for infection or inflammation. And private insurers, if they covered it at all, required pre-approval. Medicare and Medicaid has reversed that position as of January 2021, and it's now investigating the use of reimbursement and guidelines for guidelines and indications for FDG PET are being developed. In Canada, it's a mixed bag, basically because medical care is a provincial responsibility. In Alberta and Quebec, the indications for use of FDG PET are quite liberal and include infection and inflammation. But in most other provinces, it's restricted to oncology with minor exceptions. The capacity is also a problem. If there were a wholesale switch to FDG PET, most centers, if not all centers in Canada, would be unable to meet the demand. The other issue is because many people don't have a personal experience with the use of FDG PET, there's less incentive to promote its use and advocate for an expanded role. So what do we use it for? It's certainly the procedure of choice for infection of unknown origin or fever of unknown origin. It's quick and easy, and the results are available in the matter of hours. And here you see a case with pneumonia and a patient with multi-cystic disease of the kidneys and liver and some infected liver cysts. Because FDG PET isn't available universally, I'll also mention alternatives, and a frequently used one is technetium labeled white blood cells. Here you have a patient with MSSA bacteremia and no known source. If you look at the expanded image on the right at the level of the arrow, there's a subtle area of decreased metabolic activity in a mid-thoracic vertebra, and maybe slightly increased activity above that. It wasn't recognized at the time, and SPECT CT wasn't done. But the patient developed back pain, and MR showed clear spine infection. A PET CT was done to assess treatment response, and the abnormal activity is, my cursor, clearly evident on the FDG PET image. Because the spine is a relative blind spot for white blood cell imaging, we explored the use of FDG. And here's a typical case of active spine infection. The disease is often indolent. The presentation is non-specific, and many of the patients have comorbidities that make clinical diagnosis even more difficult. So by the time the patient presents, the disease is typically quite advanced. Hematogenous spine infection starts in the vertebral end plates. Proteolytic enzymes destroy the disc when the infection breaks into the disc space, and then it penetrates the adjacent vertebral body. So in active disease, you typically see uptake in bone, and it may extend into the adjacent soft tissues and into the spinal canal. During our first prospective study, we didn't know what to expect, so we did a baseline examination, and we elected to do a follow-up 6 weeks later because most clinical regimens involve 6 weeks of IV antibiotic therapy. So we thought quantification or semi-quantitative measurements like SUV max may be of value, and clearly, if you look at normal patients, they have significantly lower activity than patients with proven infection. But our hope that a decreasing activity would be able to differentiate between patients who had a successful outcome and those who had persistent active infection at the end of the IV antibiotic course did not pan out to be true. There is a slight fall in the good responders, but significant overlap, and similar findings in the patients who responded poorly. And the differences were not statistically significant. So when you look at the follow-up images on the patients who were good responders, you see this kind of a pattern. The vertebrae are partially destroyed, but there is sclerosis at the adjacent end plates, and the abnormal metabolic activity is confined within this disc space. So these patients had already completed their therapy or were at the end of the IV phase of the treatment and did not recur. So this can't represent residual infection, and we postulated that it must be some mechanically induced inflammation of the bone ends, basically grinding one on top of another, inducing the inflammatory response. If you looked at the patients who were poor responders, they had persistent abnormal activity in the bone, in the soft tissues, or in the spinal canal. So even though the numbers were very small, the findings were consistent, and we concluded that all that was really necessary is a PET-CT at the time of completion of the course of antibiotics. A baseline examination is unnecessary to the interpretation and probably wouldn't be available in the majority of cases anyways. So we just offered it as a clinical service, as a single examination without a baseline, and it produced very high sensitivity and specificity for the diagnosis of spine infection. And the indication was in patients who either couldn't have an MRI, couldn't have enhancement, had an inadequate study, inconclusive results, or the MRI interpretation was discordant with the clinical expectations. As on the original study, if you use quantification with SUV max, the sensitivity and specificity are significantly lower. If you use FDG PET for looking at treatment response, the negative examinations, the negative predictive value was 97%. 66 patients had no recurrence on follow-up, and 2 patients had a recurrence. If the interpretation was positive for infection and on review it was deemed to be correct, the indeterminate patients had continued antibiotic therapy, so we couldn't differentiate those with a persistent infection that needed the treatment from those who had already been successfully treated, but where antibiotics were withheld all patients had progression of infection or recurrence. Some of the patients, the initial interpretation was deemed incorrect, and we revised our interpretation criteria to eliminate that possibility, and some appear to have a partial response, but of the 3 patients who had antibiotics stopped, none had recurrence of infection, and they were deemed false positive. So the ones that were deemed incorrect interpretations on the initial interpretation had most of them had activity that appeared to extend outside the destroyed disc, but it was actually within the disc space. Bone fragments that adhere to the annulus that gets displaced outward outline the extent of the joint. And you can see that the abnormal activity that was considered to be in the soft tissues is actually within the confines of the expanded joint. For those of you who are interested in the details, the revised interpretation criteria are detailed in a paper in CARJ in 2018. We recently reviewed our results for assessing treatment response with the revised criteria, and we had 107 patients from 2017 to 2020. 69 had no evidence of infection, and an additional 24 on a follow-up PET CT after an initial positive study. None of the patients had clinical recurrence, although one had positive cultures for an avirulent organism, Propionibacterium acnes, at surgery performed to correct deformity after 3 days after the PET CT. That gives a negative predictive value of 99%. All active patients were treated for infection until resolution. I guess that illustrates that the confidence in the results of PET CT had increased significantly since the initial series. But 11 patients had minor abnormalities that were not typical of active inflammation, as we see in the top row here. All the activity appears to be within the destroyed joint, but there's no end plate sclerosis, and some bone fragments in the middle, so there's really no bone-on-bone contact to cause inflammation from the grinding. Some patients had very low-grade activity, as we see here. The psoas muscle is expanded, and at the edge are low-grade foci of increased activity. These typically, soft tissue infection typically responds rapidly to antibiotic therapy because it's antibiotics can readily get to that location. Typically, soft tissue abnormalities resolve completely with successful treatment. Just for interest, here's typical mechanically induced inflammation in destroyed facet joints. And here's another case who had pyogenic spine infection at that's L23, and here we see typical mechanical inflammation. Less severe mechanical inflammation is seen at degenerative disc disease at lower levels, but there are also 2 small discrete epidural foci. And patients who had this pattern, 8 of them had abnormalities at the time that antibiotic treatment was stopped, and 2 of those 8 patients recurred. Actually, the 2 illustrated on top. So we probably need to introduce a third category of risk. One high risk for patients with typical findings of infection, a low risk for recurrence if there's no evidence of infection, and an intermediate risk category where some of the patients will recur, although a majority will not, and a trial of stopping antibiotics should be considered depending on other clinical risk factors. Just a comment on comparison between MR and FDG PET. FDG labels the white cells specifically, but the enhancement and edema on MR is the result of cytokines and other vascular agents that diffuse away from the white cells until they're stopped by a barrier, in this case the cortical bone in the end plates or longitudinal ligaments, or until they're diluted sufficiently to lose effect. And that's why FDG PET allows you to differentiate mechanical inflammation at the margins of a joint and in the presence of successfully treated infection, and to recognize abnormal infection in bone, soft tissue, or in the spinal canal, whereas MRI cannot. Just a quick word on granulomatous infection, which spares the disc. This is brucellosis, and whenever you see sparing of the disc with infection spreading around it, you have to think of tuberculosis and basically a variety of non-pyogenic organisms. I won't get into post-operative spine infection because my time is running out, so I'll just go to the last slide, and it summarizes what we use, where it says default is when we try to do FDG PET at all costs, or whenever that's possible, and that's for FDG, for FUO, for all categories of spine infection, and for implanted cardiac devices. For FUO, gallium is probably the best alternative because it gives you the option to see infectious and inflammatory conditions as well as neoplasm. If infection is the most likely possibility, then white cells offer the best alternative. For spine infection, white cells cannot be recommended, and gallium is limited. Axial osteomyelitis, because of the high resolution of PET at depth, is the preferred modality, but other conditions provide reasonable alternatives. For peripheral osteomyelitis, white blood cells and gallium are also realistic, and for vascular stenosis infection, all are also reasonable options. I'll stop here, and I'm sure we'll discuss it further during the question period.
Thank you so much. Thank you so much, Dr. Kloiber. It's time for questions. Anybody has something to ask the speakers? Yeah, come forward. There's a speaker there, so
For all presenters, what's the optimal time waiting, like post-surgically or post-debridement for infection scans?
Dr. Jen, would you like to take that?
Okay, that's probably to me the most difficult of all questions. I think I know what I do personally. I first of all remind the clinician that in the immediate post-operative period, you're out of luck. Like, I don't think there's any particular tracer that's going to reliably tell you. Now, with time, as time progresses, you get a better sense of what's true post-operative and what's true residual active infection. And I think in that regards, the FDG PET is excellent. And we're, in non-pure infection cases, such as, for example, tumor, right? We see routinely, we have a good sense of post-surgical and what's, true post-surgical change versus tumor slash, and even then, sometimes it's going to boil down to progressive follow-up studies to see how it evolves. But I don't really have a good answer on that, and I try to encourage clinicians not to order the test just because they want one, and there needs to be some really good clinical indication, like an actual deterioration, a deterioration in clinical status. With that in hand, you might have a little more confidence interpreting an area of what you consider probably might be infection that's too much for just post-operative change. I don't have a good answer for that, except to try and discourage clinicians from routinely ordering one unless there is true clinical deterioration. I'd like to hear your thoughts on that, Reinhard. Do you have, what do you recommend when clinicians?
Well, I was trying to show those post-operative patients, but ran out of time. But that's probably the area where we have the most experience. The incision after spine surgery remains positive for the better part of a year. And in a series of cases that we just finished reviewing but haven't submitted for publication yet, all wound infections were diagnosed clinically. The FDG PET showed fluid collections, and even those that had a rim of increased activity around them, the majority were sterile. The real contribution of the PET and that's true of spine infection, but probably infection in other areas as well is outside the surgical field. So if it was a minimally invasive discectomy where the extruded portion of the disc only is removed and the rest remains intact, scans done even a few days after surgery showed no abnormal activity in the disc space. If hardware was inserted, if there was no complication, either infection or loosening, there was no activity at the bone hardware interface, again, even several days after the surgery. If there was infection, 95% of the cases showed extension into the bone or soft tissues outside the surgical field. So I think you can use the same thing for osteomyelitis, same approach for osteomyelitis in other areas, in that the surgical site itself in the incision is difficult to evaluate, but if it extends beyond that, you can make a definitive diagnosis of infection.
Mark? Sorry, I just want to add to that. I hearken my experience to where we have really complicated cases. So I'm talking tumor. So, the typical scenario is head and neck tumor. We do dozens of that every day, bulk volume. And from our experience, it is virtually impossible to tell. And of course, the obvious question is there remnant tumor? Is there, superimposed infection? And when the clinicians can't tell, I would say that on the PET scan, sometimes you can, but a lot of times the definitive answer is the follow-up PET, where, and in fact, the surgeons know this. They're quite well aware that we actually can't tell them 100%, and they build that right into their clinical management. And they know for a fact the definitive management decision will come on the follow-up PET CT. where we could more accurately determine, no, that's remnant tumor versus no, that's resolved post-surgical inflammation, et cetera, et cetera. But yeah, okay.
And for the bone and gallium, the immediate postoperative period is very difficult to differentiate postoperative changes from active infection. The answer is going to be the follow-up study. So the immediate post-op, the scan, the most usefulness of the post-op scan is that it is the baseline scan for assessing response to antibiotic treatment.
I have a question. Sorry, if I may, I have a question for my colleague Reinhard, if you don't mind. Many people don't realize Dr. Kloiber trained under Dr. Leonard Rosenthal, who basically developed the bone gallium paradigm for distinguishing osteomyelitis at McGill. So Reinhard, you know, it's obvious the bone gallium paradigm for interpreting infection, osteo versus not, were developed prior to the days of SPECT-CT, correct? They're basically planar imaging criteria. And I'm sure that when you trained, you know, all of those suggestions were using planar imaging. I mean, this is theoretical, but do you think that if Dr. Rosenthal was around, he would probably want to further investigate how you apply those ideas in the modern day of SPECT-CT? You know, like I don't think those criteria necessarily translate easily to SPECT-CT, where, you know, we can at will change the apparent intensities of how gallium or bone looks, you know, voluntarily. And so I personally, when I practice, I still take the publications and use them as originally intended. That is to say, with planar imaging at hand, when I try to distinguish congruence versus incongruence, and then we'll use the SPECT-CT for anatomy and distribution. Reinhard, what do you think?
Well, SPECT-CT is technically very difficult. I mean, because of the loss of resolution with a gamma camera at depth, the abnormalities tend to bloom and enlarge
Yes,
significantly.
absolutely.
The other problem is the reconstruction algorithm, where you enhance the contrast. So you, unless you're very careful, you tend to end up with a big blob that gives you an approximate idea of where the abnormality is, but overlaps into adjacent structures. So, for example, in a heel ulcer, it may be very difficult to tell whether the abnormality is confined to the soft tissues or if it extends into bone. Whereas PET-CT has enough resolution that you can actually see abnormal metabolic activity in the normally inactive fatty marrow. Looking at the overall advantages of FDG versus gallium imaging, I don't think it's difficult to conclude that FDG is far superior, not even considering factors like the time it takes to do the images, the radiation dose, and the cost. So I think gallium was very good at its time, but I think its time is limited, and I mean, availability of the product and many nuclear medicine products is in question. The other problem is that production tends to be centralized these days to minimize cost. So if there's a problem with production, the total supply chain may be disrupted. That's certainly going to be true for indium oxine, and probably for gallium as well, as we've already heard.
Mm-hmm.
I just want to say, we have the same observation with gallium, that the spatial resolution is very limited, and we always do a bone scan in conjunction with the gallium. If the gallium shows intense activity without any gallium, without any bone tracer, then there's no bone involvement. If the bone scan is abnormal, then it is positive for osteomyelitis.
Good morning. I was just wondering if you can comment a little bit more about the impact of a gallium shortage at your sites and across Canada, particularly for locations that don't have easy access to PET. How will you manage that with the gallium shortage, and if you lose total accessibility to gallium at some point?
Yeah, that is an issue with us as well. As I mentioned, that Lantheus is stopping to supply gallium as of January 1st in the new year. But we will get gallium from Curium, you know, to replace Lantheus.
Anyone who has any questions? I have a question for Dr. Kloiber. Granted that the PET has higher image quality than gamma camera-based images, why not use gallium-68 citrate?
Well, certainly gallium-68 is a wonderful radiotracer when used as a label for other radiopharmaceuticals, but gallium-68 citrate has far too short a half-life to use it for infection imaging. It's easy to remember, actually, 68 minutes half-life for gallium-68. Now, gallium citrate localizes rapidly in neoplasms and infection, but adequate contrast with normal tissue is only achieved you know, at 24 hours and later, because the normal tissues release the gallium, whereas the abnormal tissue from infection or neoplasm will retain it. So a 68-minute half-life really is way too short to achieve that optimum contrast.
Thank you. Dr. John, always there is a dilemma about acute versus chronic infection white blood cell. So is the accuracy the same if patient on acute versus chronic versus on antibiotic treatment?
Sorry, that's directed to me?
Yes.
Oh, okay. Yeah, I think the literature is controversial on this, but I think there is general agreement that I mean, first of all, it is important to know what white cell tracer you're dealing with, and in that regard, I've pointed out from the start of my talk that in our department, we've been using the technetium white cell for years, for at least 30 years, for as long as I've been practicing. And in fact, I have to say, on a personal note, I'm thankful to Dr. Kloiber, who gave me the opportunity to have some experience with indium white cell, because that's what he used in his department prior to PET-CT. So at least in theory, the indium white cell should do just fine for chronic infection, because you do have that ability to do delayed imaging into the days. And of course, the indium white cell would have that specificity advantage. And if you believe the literature, the technetium white cell that we use has reduced sensitivity when you're dealing with chronic infection. Now, I have to say that's not true in all cases. There are certain pathologies that are inherently chronic, and yet we all know very well that the technetium white cell works just fine. And so, for example, the prosthetic hip infection, for example, there is no problem there, even though that is inherently majority of the time a chronic infection. But in general, yes, and that is how we practice. We try to, when we get a request, the first thing we try to distinguish is whether you are dealing with an acute, subacute infection, whether you're dealing with chronic infection, whether there has been antibiotic therapy. And the effect of antibiotic therapy, at least for the technetium white cell, okay, that we use, again, literature on this is controversial. There are many authors who believe that you reduce your sensitivity. We do practice that way. We warn our clinicians. So whether or not you believe it, you should realize that there is literature suggesting that you have reduced sensitivity for technetium white cell anyways, once you've been on over 1 week of antibiotic therapy. So whether or not you believe it, you need to know that some clinicians are aware of that as well. And so they will have reduced confidence if you are trying to image, for example, a case for which the patient has been on over 1 week of antibiotic therapy. You need to be aware of that, and you need to warn the clinicians of that, whether or not you believe it, okay? And so we do practice accordingly. We give them that precaution. So in general, for us, if the case is chronic infection, we will defer to FDG PET, gallium, etc. If there has been more than a week of antibiotic therapy, we won't refuse to do it, but we'll provide that caution. Okay, we will attempt to perform the case as requested, but we will be cautious in our interpretation, suggesting that this may not be the definitive negative if in fact it is apparently negative. That's how we approach the question.
Thank you. Dr. Hickeson, a question for you. In places where we don't have a PET and gallium supply will be limited for spine infection, would you consider a white cell scan or a MRI scan, and why?
Again, yeah, that's a good question. I've had asked myself about the supply of gallium, and if we will have no supply of gallium at all, the supply of white blood cells will be very limited as well due to cost and availability. In MRI is also a good modality for evaluating. I would not have any preference because not all centers have an MRI and not all centers can do MRIs of the spine. So I don't have any preference whether to do white blood cell and MRI. The reason is that they both have their strength. MRI is good to delineating the extent of infection, while white blood cell is more specific. So I would
Dr.
not disagree.
Kloiber or Dr. Jen, do you have any comment about that?
Yeah, I have a comment actually.
I do too.
MR,
Yes, go ahead. Sorry, I have a comment too after you.
MR is the procedure of choice for initial diagnosis of spine infection, and that is because it's more readily available than gallium or PET-CT in most centers. It shows you where the infection is. It can tell you if there's a problem with neurologic complications, and it also allows you to differentiate potentially drainable fluid collections from phlegma. So it's clearly the procedure of choice for initial diagnosis. FDG PET or gallium would only be useful if MR is unsatisfactory for some reason. The situation for looking at treatment response is totally different. As I showed in that slide, the MR enhancement extends into all the adjacent soft tissues, and it doesn't allow you to use the criteria that we developed for interpretation of PET. That is, infection is in the adjacent bone, soft tissue, or spinal canal, and if it's confined to the joint, then you're looking at mechanical inflammation. So MR is not good for assessing treatment response, but neither is white blood cell imaging or gallium. Just one more comment on white blood cell imaging. 40% of the patients have no increased activity at all. If you're using indium white cells, you can do bone marrow subtraction, and some of them will show you a subtle increased activity after you've done the subtraction. But 60% are still abnormal. But as I showed with that case of total body white cell imaging for the patient with MSSA bacteremia, your index of suspicion for the spine has to be very, very high.
Yeah, I just want to echo what Dr. Kloiber, speaking as somebody who practices MRI, and I see the request from the other. I should remind everybody that the first test of choice, as Dr. Kloiber had already said, the first test of choice in most situations is still MRI. It's immediate access, and you should realize that clinicians are well aware of that, and that certainly a neurosurgeon would want to see an MRI before making any surgical decisions. That is the first test of choice. And I would say that even on a practical basis, if you diverted all MRI requests for assessment of initial disguise of vertebral, you would not be able to handle the volume that comes your way for the volume of potential cases that's happening outside of the nuclear medicine department. I do agree with Dr. Kloiber that the MRI will always be the first test of choice. It's difficult situations such as assessment of therapeutic response, surgical complication, instrumentation, etc., where PET absolutely has its role, and so, or bone gallium, in fact, you know, as we've already seen. But MRI probably will still be first test of choice. For other, it depends. If you're asking what happens if bone gallium is taken away from you, it depends on the specific case that you are concerned. It is location dependent. So I have strong concerns about, for example, the neuropathic foot. If you've ever seen what a neuropathic foot looks like on MRI, it's a complete disaster. If you want to talk about multiple pathologies happening concurrently, the bone reaction, the bone marrow edema, the inflammation, the sterile inflammation, never mind the infectious, it is a complete disaster. So, you know, that's why I still promote the use, as literature recommended, the use of, for the specificity, that's where white cell marrow still has a strong role for that particular specific clinical scenario. So that's all I have to say.
Thank you so much. Any questions from the audience? Okay, thank you so much, our speakers. Really appreciate the talk and the time and the comprehensive evaluation. Right now, we're going to have time for coffee, then we will come back for the next session. Thank you.
Thank you.
Thank you.